Good afternoon. I'm Tiffany Raynor. I'm a pediatric otolaryngologist. Consider you take care of a family of siblings who are healthy kids, and the parents have asked you to care for their 5-month-old who's going to be discharged from the hospital with a tracheostomy. What do you need to know to take care of that child safely? So the first thing is kind of to think about what changes when you're breathing with a tracheostomy. Normally, when we breathe air. If you don't have nasal obstruction, you breathe in air through your nose. It goes to the back of the throat, down through the vocal cords, through the trachea, into the lungs. You exhale back up through the vocal cords, either out of the mouth or out of the nose. That's the normal respiratory cycle. So with a tracheostomy, you're bypassing the entire upper airway. So the tracheostomy tube is placed in the trachea below the vocal cords, so you're bypassing the vocal cords and the nose and the mouth. Air goes directly in through the tracheostomy tube, down the windpipe into the lungs, and back out through the tracheostomy tube. So you're completely changing the respiratory cycle. And so the first thing that it's important to know is, why does the patient have a tracheostomy tube? The most common reasons that we see that kids have tracheostomy tubes are ventilator dependence, upper airway obstruction. Upper airway obstruction, there's a wide variety of pathologies: bilateral vocal cord paralysis, subglottic stenosis, which is scarring below the vocal cords in the area that's called the subglottis, micrognathia, which just means short jaw, lymphatic malformations in the tongue or in the floor of mouth. Kids that are immobile have inability to clear their lower airway secretions. They have ineffective cough. So those are kids with cerebral palsy, muscular dystrophy. And then we have kids that have a poor ability to control their oral secretions or aspiration. And in that case, the tracheostomy tube doesn't prevent aspiration, but it gives us a way to suction their secretions so that they are not soiling their airway as much. So this is sort of the anatomy of a tracheostomy tube. I'm going to see if I can come out here so I can show you. So the hub is where it's the outermost part of the tracheostomy tube, and that's where, if, for example, you were going to connect a speech valve or you were going to connect a ventilator circuit, that's where it connects. This is the flange, which sits against the skin of the neck. This is the portion of the tracheostomy tube that's inside the trachea. This particular tracheostomy tube is a cuff tracheostomy, and so there's a cuff that inflates, and the syringe attaches here to the balloon. This is an inner cannula. You won't see that as much with kids because most pediatric tracheostomy tubes are not large enough to accommodate an inner cannula. We see those much more commonly in adult tracheostomies, and so you might see that in your older kids. This is an obturator, which is kind of similar to a stylet on an endotracheal tube. So the tracheostomy tubes are relatively flexible, especially in kids. And so the obturator makes the trach tube more firm, and it also has a rounded end. So the obturator is placed in the tracheostomy tube during trach changes, when you're going to place the trach into the patient. And then once the trach's in place, you got to take the obturator out fast, otherwise they can't breathe. So these are a couple of examples of our most common brands of tracheostomy tubes. And so when you're looking at the type of tracheostomy tube, there are 4 things that you need to know. The brand, which most common are Shiley and Bavona. The size, and the size is the inner diameter of the tube. So for example, a 4.0 tube is a 4 millimeter diameter tube, inner diameter. You look at the length. So the only difference between a pediatric and a neonatal trach tube is length. A pediatric is a little bit longer than a neonatal. And then tubes come as either cuffed or uncuffed. And so typically cuffed trachs are used for patients that are requiring mechanical ventilation. And then all of the information on a particular tracheostomy tube is on the flange. So you'll have the brand, you'll have the length, either PD or neonatal, you'll have the inner diameter, which is the same as the size. And then for the cuff, you look for the balloon. If there's no balloon, there's no cuff. So the next thing that's really important when you're taking care of kids with a tracheostomy tube is that they have to have specific emergency equipment on them at all times, no matter where they are. And so the types of equipment that they must have are basically the types of things that they would need if you need to do a trach change or if you need to unblock a tracheostomy tube, mainly by suctioning. And so that would include all kids need the same size trach that they have in their neck on their person, a spare. They need a downsize, which is one size down from their regular tracheostomy tube. Any supplies that they need to change a trach, so like for a cuffed trach, that would be a syringe to deflate the cuff, lube to put on the tube. They need a suction machine and suction catheters on them at all times, and they need a resuscitation bag with them at all times. So this is an example of a go bag. When we send kids and babies home with tracheostomy tubes from the hospital at Texas Children's, we send them with a go bag. And so that's a bag that has all of the supplies that they're supposed to have on them at all times. However, there are additional things that don't fit in that bag that they have to have with them, and those include a portable suction machine. If they are vent dependent, that includes their vent, their power cords, and their batteries for the vent. Their monitoring devices, which are typically a pulse oximeter, portable oxygen, and their emergency contact phone number. So it's a lot of gear. And so if you're seeing these patients in clinic, one of the things that you're wanting to ask them is, do you have all of this? And then there's home equipment that all kids with tracheostomy tubes need. One of those is a pulse ox. So all kids with tracheostomy tubes should be wearing a pulse ox when they're sleeping. And for spot checking. So if they're looking like they're in a little bit of respiratory distress and you want to spot check their oxygen. All kids need humidification, and I'll explain that in a little bit more detail in a bit. Most kids have oxygen if they need it. Not all, but most. All kids need a suction machine, and all kids need the supplies we talked about, their trach tubes, their ties, their suction catheters. Kids with tracheostomy tubes are different than other kids in that you can't leave them with a sitter and go to dinner. These families have no respite. So anyone that is going to be caring for, first of all, they need 24/7 observation by someone who knows how to suction the trach and knows how to change the trach in case of an emergency. At TCH, we require 2 caregivers to be trained in tracheostomy care, and they go through pretty extensive educational process, which includes bedside nursing, teaching. They go through trach classes, they go through CPR classes. If the child's on a ventilator, they go through ventilator classes. They go through simulation where an instructor will take them through various tracheostomy-related emergencies and watch how they deal with those things. And then they go through a 24-hour rooming in process, which is where they're still in the hospital, but they have all of their home equipment, and they stay in a room with the parents and the child by themselves. Nurses aren't coming in and taking vitals and doing anything, and it's where the parents demonstrate their ability to care for the child at home. So typically care options are, usually it's parents or relatives. Oftentimes there will at least be some degree of home nursing care. And then some of these kids are in chronic care facilities like Healthbridge. Trach emergencies, probably of all the things to take away from this lecture, I think are the most important things because they can be fatal. There's about a 3% mortality due to tracheostomy-related complications. Usually that's related to either plugging or obstruction of the tracheostomy tube or accidental decannulation. The higher risk patients are younger patients because if their tracheostomy tube were to become occluded, there's less room for them to breathe around it because their airway is smaller. Also, infants who are not able to communicate and articulate that they need help. If there is obstruction above the tracheostomy tube, it's a bigger problem if it gets blocked. So recognizing respiratory distress in trach patients is actually really very similar to recognizing respiratory distress in other children in many ways. The first thing that you typically see is increased work of breathing. So you may see flared nostrils, rapid breathing, subcostal retractions, suprasternal retractions. If they are pale and sweaty or clammy, they're already hypoxic. So that's the next step of badness. If they're cyanotic, it's really bad. They're really hypoxic, and nobody likes blue babies. What's different with a tracheostomy tube is that breathing through a tracheostomy tube should be completely quiet. And so if you are hearing any noise from the tracheostomy tube, it is at least partially obstructed. If it's a wet sounding noise, you're hearing secretions and the patient needs to be suctioned. If it's more of a whistling sounding noise, it means that the tube is partially obstructed. If you are hearing upper airway noises like stridor or stridor, it means the tube's completely blocked and they're breathing through their upper air passage. So we go through with our families very specific instructions that we try to make relatively simple so that when you are in emergency, you know X, Y, and Z. This is what you do, 1, 2, 3, 4. So the first thing is to try and suction the tracheostomy tube. And then to try and bag through the tracheostomy tube. And you should see in the same way when you put a face mask on and bag a child through their mouth, you should see chest rise. If you're not seeing that, the next step is to change the trach out. Sometimes when you try and change the trach out, you can't get the trach back in. And so that's why we require all kids to have a downsize, because it's always a little bit easier to get one size smaller trach in if you can't get the trach in. If that's not working, the next step is going to be to try and bag from above. So to take the tracheostomy tube out, put your finger over the stoma and try and bag from above. And if things are continuing to progress, then CPR and 911 if you're in a community setting. If you're in a hospital setting, it would be code. So this is an example of an airway card that we send home with all of our kids that have tracheostomy tubes. And it's meant to provide the important information that either first responders or pediatricians need about the patient's tracheostomy and about their airway status. And so it's their current trach size, what their downsize is, what their suction depth is. All kids are provided with a suction chart so that you know how far to suction, because if you don't suction far enough, plugs develop, and if you suction too far, you can get injury to the airway and you get bleeding and things like that. And then the airway status. And the airway status is meant to include if the child has an upper airway obstruction of some type, if they have bilateral vocal cord paralysis, if they have a subglottic stenosis. The grade view of the larynx is something that can be useful for paramedics. I think it's probably easier just to say the patient can be easily intubated or cannot be easily intubated. But basically, intubation grade view goes from 1 to 4, with 1 being very easy and 4 being almost impossible. And then any special intubating instructions. So this gets to the crux of why you need to know why the trach was put in. You need to know if the patient if you are having problems with the trach, if you can't get the trach back in, can you bag them over the nose and mouth? Can you intubate them? Looking at prevention of the two biggest killers of kids with tracheostomy tubes, one is trying to prevent accidental decannulation. So one of the most important things in preventing accidental decannulation is having a secure trach tie, which means a tight trach tie. It's much tighter than you would think it would be. You really only should be able to get one finger between the trach collar and the neck. If the trach collar is looking like it's showing signs of wear or thinning, it needs to be replaced. And then this is the biggest culprit, kids pulling at their tracheostomy tubes. And we see this a lot in toddlers. Toddlers with tracheostomy tubes, unfortunately, are no different than toddlers without tracheostomy tubes in that they all have a death wish. They have no idea that they need that trach to breathe and to live, and they don't care. So for prevention of plugging, humidification is very important. As I mentioned before, when we breathe, we are taking in air through the nose, typically, which is warming and humidifying the air that we breathe. There is no natural humidification process with the tracheostomy, so patients will typically have what's called an artificial nose or a heat moisture exchanger, which is worn when they're awake, and a humidified trach collar, which is just like a mist collar that's worn during sleep. It's important that their trach is large enough that it's not becoming obstructed, and that's part of the reason that we need to see them relatively frequently. Oftentimes a mucus plug can be removed by suctioning. If it can't be removed with suctioning, we change the trach. And so we tell our parents, when in doubt, change it out. With managing of thick secretions, oftentimes it's a humidification issue, so increasing humidification. It can be an infectious issue if you're noticing other signs of respiratory infection like fever, increased work of breathing, increased oxygen requirement. Then you want to consider taking a culture and starting antibiotics. This is a picture of a speaking valve, this purple valve, which is a one-way valve that goes on the end of the tracheostomy tube. In order to speak with a tracheostomy tube, you need this one-way valve, which allows air to go in through the tracheostomy tube and out. It's blocked on the expiratory face. So it allows air in but not out. So when air goes out, it goes up through the vocal cords, allowing phonation. So what do you ask at the visit? Any problems with the trach? Bleeding, plugging, accidental decannulations? Do you have your supplies? Who's taking care of the child? Are you using your pulse ox? Are you using your humidification? Are you changing your trach monthly? Are there any problems with trach changes? And then you look at the skin under the neck to be sure you don't have any skin breakdown. So under the trach and under the ties. So in conclusion, these are the things that you need to know.